Unfortunately, in clinical signs and symptoms, they do help us in entirety make a diagnosis and lead towards the right test. But by itself, of one particular symptom is not very sensitive or specific to either
Got it.
rule in or rule out uh,
Okay.
coronavirus infection or not. So just by itself, like if somebody presents with productive cough, I would not be able to say
Hmm.
this patient does not have coronavirus. You have to look at the whole picture. But you're right. The most reported cough symptom has been reported to be dry cough rather than productive cough. But that by itself should not be the rule,
Got
and
it.
we have to look the whole picture. So let's start off with PRRT. Um, PRRT is a radiation-based targeted treatment, and it targets somatostatin receptor positive neuroendocrine tumors.
Hmm.
It can lead to some decline in white blood cells, but that's not the commonest side effect. It's the decline in platelets that we are often concerned with, usually very well tolerated. In my experience, it does not cause profound immunosuppression
Mm.
to a point where it would lead to a significant added risk for infections. At present, in Markey Cancer Center, as I mentioned, because our COVID-19 cases have not peaked and we are not even close to that, community spread, we are currently not delaying PRT. However, we are, and by me and my colleague, Dr. Lowell Anthony, we're reviewing the situation on a weekly basis,
Hmm.
and we'd be, making that call once the community infection rates have peaked and there is significant risk for acquiring COVID-19 by, for example, patient coming to healthcare facilities. We might decide at that point to delay the treatment. Um, in the NETTER-1 clinical trial, which led to its FDA approval, and the doses of PRT was spaced every 8 weeks. However, from our European colleagues, we know that PRRT or Lutathera can be spaced, and like one of my friends usually say, there's no real magic in spacing them by 88 weeks. So,
Hmm.
based on the situation for that particular cancer center and the ground realities, we can easily extend the duration, the frequency, or delay the treatment
Hmm.
without causing overt harm. This is in relation to PRD. Now, certain other chemotherapeutic drugs, we have to be careful because they can certainly cause immunosuppression, like I mentioned, Afinitor and CAPTEM.
Sure.
And the decision regarding delaying treatment or holding treatment has to be individualized. I was going over ASCO, which is American Society of Clinical Oncology. It's one of the largest medical oncology associations, and they have a guidance document on their website. Of course, the caveat is we don't have a lot of data regarding COVID-19 and what should be done
Hmm.
with regards to chemotherapeutic treatment, but they do mention that um, uh, you know that most patients should be able to proceed on with their treatment
Okay.
as scheduled, especially with regards to chemotherapy. Again, these have to be individualized based on the ground reality and individual
Sure.
patient. CAPTEM is a combination chemotherapy regimen of two drugs.
Hmm.
CAP refers to capecitabine,
Okay.
and TEM refers to temozolomide. So
Ah, okay.
no wonder why we shortened it CAPTEM rather than
Right. Right.
capecitabine temozolomide.
Right. Right.
This is a cytotoxic chemotherapy, and the unique nature of this chemo regimen is it's given orally.
Hmm.
So the first pill is taken for 14 days, the other pill is taken for 5 days from day 5 to day 14. Now, how long does somebody's is immunosuppressed is based on a couple of variables. Uh, Number one, what dose of CAPTEM they are on. Secondly, what uh, duration of treatment and duration of cycle of treatment. So often we do 2 weeks of treatment followed by 1 week off. Then we move on to cycle number two. Sometimes we do 2 week on and 2 week off. And if somebody has had stable disease for a really long time, especially over a year, we sometimes uh, reduce the frequency of cycles and we do 2 weeks on, 3 weeks off, or 4 weeks off. So it depends on what particular regimen and dose and frequency of cycle these patients are on. Typically, the blood count can be low 7 to 14 days after the treatment. I would say definitely 1 week after the treatment, but then they should start recovering back to normal. There are certain other factors which are very unique to individual patients. For example, previous history of cytotoxic chemotherapy or duration of time with that particular patient is on CAPTEM. Because the longer you're exposed to these agents, the bigger the toll it takes on your bone marrow, and your ability to bounce back from low blood count can be somewhat compromised. However, having said that, I treat a lot of small cell lung cancer where we do give a very hefty dose of platinum-based chemotherapy as compared to a lot of other cytotoxic chemotherapy. CAPTEM, in my experience, is not that myelotoxic and immunosuppressive, and it does have potential to do that. So that's why we check monthly CBC count. So anytime you get restarted on the new cycle, you're supposed to get some routine blood work to make sure your blood count has recovered before you go forward. In my experience, as compared to other chemotherapy drugs, it doesn't cause a similar degree of lymphocytopenia or neutropenia. But again, having said that, there are a lot of variables which are individual patient related, as well as what dose and frequency of CAPTEM they're on. That's a good question. And, somatostatin analogs, both cytostatin and lanreotide, are, they form the backbone for our treatments. And a lot of our patients are on these somatostatin analogs. Should they be delayed during this? Again, these are the decisions which have to be made individually at individual level between the physician and the patient. And I think some of the guiding principles would be one, what is the role of somatostatin analog for that particular patient? Is it just for tumor control, or is it for syndrome control? If I have a patient with carcinoid syndrome diarrhea, I would definitely want them to continue this treatment. Otherwise, they would have the symptoms as for which they'd either have to then use multiple short-acting shots. So certainly it depends on what are we treating them for. I would also like to mention, a couple of years back, FDA approved another treatment called Zermelo, which is a pill form of treatment for carcinoid syndrome diarrhea, not controlled adequately with somatostatin analogs. That is I think in these kind of times, a pretty good treatment option, because the pills can be taken at home. So something to definitely consider if we are talking precisely for carcinoid syndrome diarrhea control. If the somatostatin analog shot is for tumor control, again, in Kentucky, in Lexington, based on the current situation, we are not delaying the treatment. However, come May, when our cases are anticipated to be peaking, yes, for the asymptomatic, stable patients with very indolent disease, I might delay their treatment to mitigate their risk, because at the end of the day, these are not curative treatments. These are, and I would like to reduce the risk of acquiring an infection, which might actually end up be more detrimental in short run. So you have to make these decisions based on individual situation. I don't think there's any issues with continuing octreotide. Octreotide, to my knowledge, is not an immunosuppressant. I think the only worry certain colleagues at certain places would be based on the ground situation. Is there any added risk for the
Mm-hmm.
patient coming to a healthcare facility of him acquiring COVID-19?
Mm-hmm.
And those things have to be dealt at local level. Again, every state in the United States are in a very different phase of community infection rates. For example, Lexington, Kentucky, we are supposed to have peak rates in May. So things are basically functioning normally, at least for the cancer patient in our center right now. These things might change as situations very fluid. So it depends. As somebody is in New York, things are completely different, and I think uh, if a routine care, again we mentioned earlier, if somebody is on sandostatin or lanreotide for just disease controls, rather asymptomatic patients has a well-controlled disease for several months, in fact years. I think looking at situation, they can potentially uh, delay or reschedule their
Mm-hmm.
shot. But per se, sandostatin by itself does not cause immunosuppression, so it's a safe drug to go. I wish, maybe this could be an opportunity for our industry partners who make sandostatin and lanreotide to push for a legislation where we can provide these shots to our patients at home, like in Europe. So in Europe, patients can get these monthly shots at home with the help of home health. But here, the way our I think reimbursement structure or billing structure is, I think it's not allowed to be given at home. Again,
Mm-hmm.
this is something I think we should use this as an opportunity to kind of work towards this. That is completely okay.
Okay.
Lanreotide is a somatostatin analog and is does not cause immunosuppression. Um, if your healthcare provider are providing these cares and are not considering delaying based on the situation in your area, it's completely safe. It does not put you at added risk for complications from COVID-19. Again, I think there are factors besides just the drug and the host, which will dictate whether there should be we should consider delaying treatment. That would be based on the healthcare scenario of that particular area. You don't want to be going to the hospital if
Mm-hmm.
there are tons and tons of COVID-19 cases in that particular
So,
area.
so if you delayed your lanreotide injections, that would be okay as well.
Absolutely. If
Okay.
somebody is on lanreotide just for tumor control, for rather indolent disease, I think it's very safe to
Okay.
delay it as well. I would not get too anxious if it gets delayed. One of the neat things about especially low-grade neuroendocrine tumor is that it's an indolent disease. It doesn't grow very fast. Again,
Mm-hmm.
these are I hate to make these blanket statements because a lot also depends on the individual grade of the tumor. But for most patients with low-grade disease, it's a very slow-growing cancer, unlike some of our other cancers like breast cancers or small cell lung cancer or leukemias. So it's a very different disease, and I feel very comfortable holding
Good.
the treatment if that's the need of the hour for that particular place in the community. So that's a real concern.
Mm.
And because of that concern, a lot of society, especially surgical society of oncology and other healthcare societies are grappling with this question regarding surgeries because surgeries come with a period of convalescence, and these patients can be in the hospital, and being in hospitals added risk for nosocomial infections,
Mhm.
etc. So, since the viewer you're alluding to it already had the surgery, a lot of places people are delaying elective surgeries if
Sure.
possible. That's our current guidelines, and same here in Lexington. If it's an elective surgery, we are trying to delay it. However, somebody's already had surgery. Of course, I would defer to the local team of the surgeons, but as soon as the patient can be discharged home and safe for him to be home, I think home is a good environment to be in. And if this is a very unique situation because the patient's family member, very close family member, is also a healthcare provider.
Right.
And I would, what I'm doing personally, uh,
Yeah.
except for your event today, I wore a dye and a jacket. I'm usually moved to scrubs, and my game plan is to use scrubs, and as soon as I reach home, I dump them into the washer, change to a clean piece of clothes, keep my hands clean, wash my hands often, and maintain, in this particular scenario, probably safe to maintain about 6 feet of distance if somebody is high risk and
Hmm.
their spouse is working frontline in ER or ICU. You would see on Twitter a lot of healthcare providers are trying to maintain that distance with the close family because they're scared that
Yeah.
they would infect
Major.
their family members. This is an evolving situation. Unfortunately, I don't have a good answer for this, and we just need to use our judgment and try to mitigate that risk. Social distancing, hand hygiene, cleanliness, and avoid sick people. If your wife does get symptoms, I would probably use mask. She should use mask and of course
Okay.
try to distance as much as possible.